18. Fecal incontinence. Satish S. C. Rao. Fecal incontinence is defined as the involuntary leakage of fecal matter through the anus or inability to control the discharge of bowel contents. Its severity can range from occasional unintentional loss of flatus to seepage of liquid fecal matter or complete evacuation of bowel contents. Consequently, the problem has been difficult to characterize from an epidemiologic and pathophysiologic standpoint, but it causes considerable embarrassment, loss of self-esteem, social isolation, and diminished quality of life. QOL. Point 1. Epidemiology. Fecal incontinence affects people of all ages, but its prevalence is disproportionately higher in middle-aged women, older adults, and nursing home residents. Estimates of its prevalence vary greatly and depend on the clinical setting, definition of incontinence, frequency of occurrence, and influence of social stigma and other factors. Point 2. The embarrassment and social stigma attached to fecal incontinence make it difficult for patients to seek health care. Treatment is often delayed for several years. Fecal incontinence not only causes significant morbidity but also consumes substantial healthcare resources. In a U.S. householder male survey, frequent leakage of stool and fecal staining for more than 1 month were reported by 7.1% and 0.7% of the population, respectively. Point 3. In the United Kingdom, 2 or more episodes of fecal incontinence per month were reported by 0.8% of patients who presented to a primary care clinic. Point 4. In an older, age 65, self-caring population, fecal incontinence occurred at least once a week in 3.7% of patients and in more men than women. Ratio of 1.5, 1.5. The frequency of fecal incontinence increases with age, from 7% in women younger than 30 to 22% in women in their 7th decade. 6,7. By contrast, 25% to 35% of institutionalized patients and 10% to 25% of hospitalized geriatric patients have fecal incontinence. Point 1. In the USA, fecal incontinence is the second leading reason for placement in a nursing home. In a survey of 2,570 households comprising 6,959 individuals, the frequency of at least one episode of fecal incontinence during the previous year was 2.2%. Among affected persons, 63% were 232 women, 30% were older than 65, 36% were incontinent of solid stool, 54% were incontinent of liquid stool, and 60% were incontinent of flatus. Point 1. A National Institute of Diabetes and Digestive and Kidney Diseases, NIDK, workshop of experts concluded that the frequency of fecal incontinence in community dwelling women and men averages from 7% to 15%. Point 8. In another prospective survey of patients who attended either a gastroenterology or primary care clinic, over 18% reported fecal incontinence at least once a week. Point 9. Only 1/3 had ever discussed the problem with a physician, thereby suggesting that fecal incontinence is underreported. When stratified for the frequency of episodes, 2.7% of patients reported incontinence daily, 4.5% weekly, and 7.1% monthly. Point 9. In another survey, fecal incontinence was associated with urinary incontinence in 26% of women who attended a urology-gynecology clinic. Point 10. A high frequency of mixed fecal and urinary incontinence was also reported in nursing home residents. Fecal incontinence has a significant impact on the QOL, including loss of self-respect, confidence, and modesty. Point 8.11. It also has an impact on psychological domains, including coping strategies, anxiety, fear, embarrassment, personal hygiene/odor issues, and unpredictability of stool habit. Point 8. Furthermore, there is a significant correlation between symptom severity and QOL. Point 12. Also, persons with incontinence were 6.8 times as likely to miss work or school and missed an average of 50 work or school days per year compared with those without incontinence or other functional GI symptoms. Point 3. The cost of healthcare related to fecal incontinence includes measurable components like evaluation, diagnostic testing, and treatment of incontinence, as well as use of disposable pads and other ancillary devices, skin care, and nursing care. Roughly $1.8 billion per year was spent on adult diapers in the USA alone, and globally $10.70 billion, 13 and between $1.50 and $7 billion/year is spent on care for incontinence among institutionalized older patients. 1,2,14 When adjusted for 2012 dollars, the total per patient annual cost was slightly higher in the USA, $84,111, than in the Netherlands, $83,521. 15 The potential economic impact of non-surgical therapy for fecal incontinence, such as sacral nerve stimulation, SNS, was estimated in the United Kingdom to be more than $35,000 per year. 16 But there are no prospective cost-effectiveness comparative trials. In a long-term facility, the annual cost for a patient with mixed fecal and urinary incontinence was $9,711.17 in the outpatient setting. The average estimated cost per patient, including evaluation, is $17,166.18. These persons also incur costs that cannot be easily measured and result from their impaired QOL and social dysfunction. 7 Fecal incontinence causes a significant economic burden, including increased use of healthcare resources, and has a major impact on QOL. Pathophysiology. Functional anatomy and physiology of the anorectum. A structurally and functionally intact anorectal unit is essential for maintaining normal continence of bowel contents. See chapters 100 and 129. 19 The rectum is a hollow muscular tube composed of a continuous layer of longitudinal muscle that interlaces with posterior anterior. Fig. 18.1 Sagittal diagrammatic view of the anorectum. From Rao SSC. Pathophysiology of adult fecal incontinence. Gastroenterology 2004, 126s 1422. The underlying circular muscle. This unique muscle arrangement enables the rectum to serve as both a reservoir for stool and a pump for emptying stool. The anus is a muscular tube 2 to 4 cm in length that at rest forms an angle with the axis of the rectum. Fig. 18.1. At rest, the anorectal angle is approximately 90 degrees. With voluntary squeeze, the angle becomes more acute, about 70 degrees, and during defecation the angle becomes obtuse, about 110 to 130 degrees, see chapter 19. The anal sphincter consists of two muscular components, the internal anal sphincter, IAS, a 0.3 to 0.5 cm thick expansion of the circular smooth muscle layer of the rectum, and the external anal sphincter, EAS, a 0.6 to 1.0 cm thick expansion of the levator ani muscles. Morphologically, both sphincters are separate and heterogeneous. 20 The IAS is composed predominantly of slow-twitch, fatigue-resistant smooth muscle and generates mechanical activity with a frequency of 15 to 35 cycles/min as well as ultra-slow waves at 1.5 to 3 cycles/min. 19 The IAS contributes 70% to 85% of the resting anal sphincter pressure, but only 40% of the pressure after sudden distension of the rectum and 65% during constant rectal distension. The remainder of the pressure is provided by the EAS or puba rectalis, or both. 21 Therefore, the IAS is chiefly responsible for maintaining anal continence at rest. The anus is normally closed by the tonic activity of the IAS. This barrier is reinforced during voluntary squeeze by the EAS. The EAS, although circumferential in its inner layers, may also have a purse string configuration in some of its outer layers anteriorly with fibers inserting into the contralateral transverse perineal and bulbospongiosus muscles and pubic rami. 22 This unique configuration may have implications for episiotomy and anal sphincter reconstruction. The anal mucosal folds, together with the expansive anal vascular cushions, see later, provide a tight seal. 23 These barriers are augmented by the puba rectalis muscle, which forms a flap-like valve that creates a forward pull and reinforces the anorectal angle. 19 Studies using high-definition three-dimensional, 3D, manometry have revealed that the puba rectalis muscle contributes significantly to the pressure profiles and plays an integral role in maintaining continence, sensory motor response, and the rectoanal inhibitory reflex. See later. 24 The anorectum is richly innervated by sensory, motor, and autonomic nerves and by the enteric nervous system. The principal nerve to the anorectum is the pudendal nerve, which arises from the second, third, and fourth sacral nerves, S2, S3, S4, innervates the EAS, and subserves sensory and motor function. 25 A pudendal nerve block creates a loss of sensation in the perianal and genital skin and weakness of the anal sphincter muscle but does not affect rectal sensation. 21 A pudendal nerve block also abolishes the recto-anal contractile reflexes. See later, an observation that suggests that pudendal neuropathy may affect the recto-anal contractile reflex response. The sensation of rectal distension is most likely transmitted along the S2, S3, and S4 parasympathetic nerves. These nerve fibers travel along the pelvic splanchnic nerves and are independent of the pudendal nerve. 19 How humans perceive stool contents in the anorectum is not completely understood. Earlier studies failed to demonstrate rectal sensory awareness. 19 Subsequent studies have confirmed that balloon distension is perceived in the rectum and that such perception plays a role in maintaining continence. 23,26 Furthermore, sensory conditioning can improve hyposensitivity 27,28 and hypersensitivity 29 of the rectum. Mechanical stimulation of the rectum can produce cerebral evoked responses 30 confirming that the rectum is a sensory organ. Likewise, electrical stimulation of the anus and rectum also evokes cortical evoked potentials, both in health 31 and in patients with fecal incontinence. 32 Although organized nerve endings are not present in the rectal mucosa or myenteric plexus, myelinated and unmyelinated nerve fibers are present. 19 These nerves most likely mediate the distension or stretch-induced sensory responses as well as the visceral 30 recto-anal inhibitory, and recto-anal contractile reflexes. The sensation of rectal distension is most likely transmitted via the parasympathetic nervi erigents along the S2, S3, and S4 splanchnic nerves. Rectal sensation and the ability to defecate can be abolished completely by resection of the nervi erigents. 33 If parasympathetic innervation is absent, rectal filling is perceived only as a vague sensation of discomfort. Even persons with paraplegia or sacral neuronal lesions may retain some degree of sensory function, but almost no sensation is felt if lesions occur in the higher spine. 16,2034 Studies using novel non-invasive magnetic stimulation of lumbosacral plexus and recordings of anal and rectal motor evoked potentials, MEPS, have shown that patients with spinal cord injury and fecal incontinence exhibit significant lumbosacral neuropathy. 35-36 Therefore, the sacral nerves are intimately involved in the maintenance of continence. The suggestion has been made that bowel contents are sensed periodically by anorectal sampling. 37 The process whereby transient relaxation of the IAS allows the stool contents from the rectum to come into contact with specialized sensory organs in the upper anal canal. Specialized afferent nerves may exist that subserve sensations of touch, temperature, tension, and friction, but the mechanisms are incompletely understood. 19 Incontinent persons appear to sample rectal contents less frequently than continent persons. The likely role of anal sensation is to facilitate discrimination between flatus and feces and the fine-tuning of the continence barrier, but its precise role has not been well characterized. Rectal distension is associated with a reflex decrease in anal resting pressure known as the recto-anal inhibitory reflex. The amplitude and duration of this relaxation increases with the volume of rectal distension up to a maximum of 100 to 150 cubic centimeters and then plateaus. 38 This reflex is mediated by the myenteric plexus and caused by the release of nitric oxide and vasoactive intestinal peptide 39 and is present in patients in whom the hypogastric nerves have been transected and in those with a spinal cord lesion. The reflex is absent after transection of the rectum, but it may recover. 26 The recto-anal inhibitory reflex may facilitate discharge of flatus and stool. Rectal distension is also associated with a recto-anal contractile response, a subconscious reflex effort to prevent release of rectal contents such as flatus. 40,41 This response involves contraction of the EAS and is mediated by the pelvic splanchnic and pudendal nerves. The amplitude and duration of the recto-anal contractile reflex also increases with rectal distension, up to a maximum volume of 30 ml. Abrupt increases in intra-abdominal pressure, as caused by coughing or laughing, are associated with an increase in anal sphincter pressure. A number of mechanisms, including reflex contraction of the puborectalis, may be involved. More recently, a rectoanal sensorimotor reflex response has been described, whereby the conscious perception of a desire to defecate, induced by balloon distension, evokes a contractile response in the anal canal. 42 This response is primarily mediated by contraction of the puborectalis. 38 and is significantly impaired in patients with rectal hyposensitivity. 43 The blood-filled vascular tissue of the anal mucosa also plays an important role in producing optimal closure of the anus. An in vitro study has shown that even during maximal involuntary contraction, the internal sphincter ring is unable to completely close the anal orifice. A gap of some 7 mm remains. This gap is filled by the anal cushions, which may exert pressures of up to 9 mm Hg and thereby contribute 10% to 20% to the resting anal pressure. 40 Pathogenic mechanisms. Fecal incontinence occurs when one or more mechanisms that maintain continence is disrupted to the extent that other mechanisms cannot compensate. Therefore, fecal incontinence is often multifactorial. 2,41 In a prospective study, 80% of patients with fecal incontinence had more than one pathogenic abnormality, Fig 18.2.19. Although pathophysiologic mechanisms often overlap, they can be categorized under 4 broad groups, Table 18.1. Frequency, %. Fig 18.2 Relative frequencies of common mechanisms that lead to fecal incontinence. In many patients, more than one mechanism is involved. Abnormal anorectal and pelvic floor structures. Anal sphincter muscles. Disruption or weakness of the EAS muscle causes urge-related or diarrhea-associated fecal incontinence. By contrast, damage to the IAS muscle or anal endovascular cushions may lead to a poor seal and an impaired sampling reflex. These changes may cause passive incontinence or fecal seepage, see later, often under resting conditions. Both sphincters may be defective in many patients. The extent of muscle loss can influence the severity of incontinence. 19 Table 18.1 Mechanisms, causes, and pathophysiology of fecal incontinence. Mechanism. Causes. Pathophysiology. Abnormal anorectal or pelvianal sphincter muscles. See floor structures. Hemorrhoidectomy, neuropathy, obstetric injury. Sphincter weakness, loss of sampling reflex. Puborectalis. Muscle aging, excessive perineal descent, trauma. Obtuse anorectal angle, sphincter weakness. Pudendal nerve. Excessive straining, obstetric or surgical injury, perineal descent. Impaired reflexes, sensory loss, sphincter weakness. Nervous system, spinal cord, autonomic nervous system. Avulsion injury, diabetes mellitus, head injury, multiple sclerosis, spinal cord injury, spine surgery, stroke. Impaired reflexes, loss of accommodation, loss of sensation, secondary myopathy. Rectum aging, IBD, IBS, prolapse, radiation hypersensitivity, loss of accommodation, loss of sensation. Abnormal anorectal or pelvic floor function, impaired anorectal sensation. Autonomic nervous system disorders, CNS disorders, obstetric injury. Loss of stool awareness, rectoanal agnosia. Fecal impaction. Dyssynergic defecation. Fecal retention with overflow, impaired sensation. Altered stool characteristic. Increased volume and loose consistency. CS. Bile salt malabsorption, drugs, infection, IBD, IBS, laxatives, metabolic disorders. Diarrhea and urgency, impaired accommodation, rapid stool transport. Hard stools, retention drugs. Dyssynergia. Fecal retention with overflow. Miscellaneous. Physical mobility, cognitive function. Aging, dementia, disability. Multifactorial changes. Psychosis. Willful soiling. Multifactorial changes. Drugs. Anticholinergics, antidepressants, caffeine, laxatives, muscle relaxants. Constipation. Altered sensation, constipation. Relaxation of sphincter tone. Diarrhea. Relaxation of sphincter tone. Food intolerance. Fructose, lactose, or sorbitol malabsorption. Diarrhea, flatus. Pathophysiology is noted for each class of drugs. The most common cause of anal sphincter disruption is obstetric trauma, which may involve the EAS, IAS, or pudendal nerves. However, why most women who have sustained an obstetric injury in their 20s or 30s typically do not present with fecal incontinence until their 50s is unclear. In a prospective study, 35% of primiparous, normal antepartum, women showed evidence of anal sphincter disruption after vaginal delivery. 44,45 Other important risk factors include a forceps-assisted delivery, prolonged second stage of labor, large birth weight, and occipito-posterior presentation. 19 A prospective study of 921 primiparous women has shown that the frequencies of fecal incontinence at 6 weeks and 6 months postpartum are 27% and 17%, respectively, in women with vaginal delivery. And a sphincter tear, 11% and 8%, respectively, in women with vaginal delivery but without a tear, and 10% and 7.6%, respectively, in women who underwent caesarean section. 46 This study showed clearly that the occurrence and severity of fecal incontinence were due to an anal sphincter tear that occurred at the time of vaginal delivery. Episiotomy is believed to be a risk factor for anal sphincter disruption. In one study, medial episiotomy was associated with a 9-fold higher risk of anal sphincter dysfunction. 47 Regardless of the type of delivery, however, incontinence of feces or flatus occurred in a surprisingly large percentage of middle-aged women, thereby suggesting that age-related changes in the pelvic floor may predispose to fecal incontinence. Aging affects anal sphincter function. 48 In men and women older than age 70, sphincter pressures decrease by 30% to 40%, compared with younger persons. 49 In all age groups, anal squeeze pressure is lower in women than men. 49 With a rapid fall after menopause. 50 Estrogen receptors have been identified in the human striated anal sphincter, and ovariectomy in rats leads to atrophy of the striated anal sphincter muscle. 19,51 These observations suggest that the strength and vigor of the pelvic floor muscles are influenced by hormones. Pudendal nerve terminal motor latency, PNTML, is prolonged in older women, and pelvic floor descent is excessive on straining, see later. 52 These mechanisms may contribute to progressive damage to the striated anal sphincter muscle. Aging is also associated with increased thickness and echogenicity of the IAS. 53 Other causes of anatomic disruption include anorectal surgery for hemorrhoids, fistulas, and fissures. Anal dilation or lateral sphincterotomy may result in incontinence secondary to fragmentation of the anal sphincters. 54 Hemorrhoidectomy can cause incontinence by inadvertent damage to the IAS 55 or loss of endovascular cushions. Accidental perineal trauma or a pelvic fracture may also cause direct sphincter trauma that leads to fecal incontinence. 56 But anoreceptive intercourse is not associated with anal sphincter dysfunction. 57 Finally, IAS dysfunction may also occur because of myopathy, degeneration, or radiotherapy. 19 Puborectalis muscle. The puborectalis muscle is important for maintaining continence by forming a flap valve mechanism. 58 Studies using 3D US have shown that 40% of women with fecal incontinence have major abnormalities, and another 32% have minor abnormalities, of the puborectalis muscle, compared with 21% and 32%, respectively, of asymptomatic paris controls. 59 Assessment of puborectalis function by a perineal dynamometer revealed impaired puborectalis, levator ani, contraction in patients with fecal incontinence, and this finding was an independent risk factor for and correlated with the severity of fecal incontinence. 60 Furthermore, improvement in puborectalis strength following biofeedback therapy was associated with clinical improvement, in part because the upper portion of the puborectalis muscle receives its innervations from branches of the S3 and S4 sacral nerves rather than the pudendal nerve. Because the puborectalis muscle and EAS have separate neurologic innervations, pudendal blockage does not abolish voluntary contraction of the pelvic FLOOR61 but completely abolishes EAS function. 21 Nervous system intact innervation of the pelvic floor is essential for maintaining continence. Sphincter degeneration due to pudendal neuropathy and obstetric trauma may cause fecal incontinence in women. 44 Neuropathic injury is often sustained during childbirth, probably as a result of stretching of the nerves during elongation of the birth canal or direct trauma during passage of the fetal head. Nerve damage is more likely to occur when the fetal head is large, the second stage of labor is prolonged, or forceps are applied, especially with a high forceps delivery or prolonged labor. The role of extrinsic autonomic innervation is controversial. Animal studies have shown that the pelvic nerves convey fibers that relax the rectum. 62. These nerves may play a role in accommodating and storing feces and gas. Damage to the pelvic nerves may lead to impaired accommodation and rapid transit through the rectosigmoid region, thereby overwhelming the continence barrier mechanisms. Sympathetic efferent activity, as studied by stimulating the presacral sympathetic nerves, tends to relax the IAS, whereas parasympathetic stimulation may cause contraction of the anal sphincter. The upper motor neurons for voluntary sphincter muscle lie close to those that innervate the lower limb muscles in the parasagittal motor cortex and adjacent to the representation of the genitalia and perineum in the sensory cortex. 19 Damage to the motor cortex from a CNS lesion may lead to incontinence. In some patients with neurogenic incontinence, the sensory and motor nerve fibers may be damaged, resulting in sensory impairment. 63 This damage can impair conscious awareness of rectal filling as well as the associated reflex responses in the striated pelvic floor sphincter muscles. Approximately 10% of patients with fecal incontinence may have a lesion more proximal than the intrapelvic or perianal nerves. The primary abnormality in these patients is cauda equina nerve injury. 64 which may be occult and not evident through clinical evaluation. These patients have a prolongation of nerve conduction along the cauda equina nerve roots without an abnormality in PNTML. 65 In a minority of patients, however, a combination of peripheral and central lesions is present. Other disorders such as multiple sclerosis, diabetes mellitus, and demyelination injury, or toxic neuropathy from alcohol or traumatic neuropathy, may also lead to incontinence. 19 Rectum The rectum is a compliant reservoir that stores stool until social conditions are conducive to its evacuation. 2 If rectal wall compliance is impaired, a small volume of stool material can generate a high intrarectal pressure that can overwhelm anal resistance and cause incontinence. 66 Causes include radiation proctitis, UC, or Crohn's disease, infiltration of the rectum by tumor, and radical hysterectomy. 67 Similarly, rectal surgery, particularly pouch surgery. 68 And spinal cord injury. 69 may be associated with loss of rectal compliance. Abnormal anorectal and pelvic floor function. Impaired anorectal sensation. Intact sensation not only provides a warning of imminent defecation but also helps distinguish among formed stool, liquid feces, and flatus. Older persons, those who are physically and mentally challenged, and children with fecal incontinence 70 often show blunted rectal sensation. Impaired rectal sensation may lead to excessive accumulation of stool, thereby causing fecal impaction, megarectum, extreme dilatation of the rectum, and fecal overflow. Causes of impaired sensation include neurologic damage due to multiple sclerosis, diabetes mellitus, and spinal cord injury. 69 Less well known is that analgesics, particularly opiates, and antidepressants may also impair rectal sensation and produce fecal incontinence. The importance of the rectum in preserving continence has been demonstrated conclusively through surgical studies in which preservation of the distal 6 to 8 cm of the rectum, along with its parasympathetic nerve supply, helped patients avoid incontinence. 71 By contrast, rectal sensation and the ability to defecate can be abolished completely by resection of the nervi erigents, see earlier. 33 An intact sampling reflex allows an individual to choose whether to discharge or retain rectal contents. Conversely, an impaired sampling reflex may predispose a subject to incontinence. 37 The role of the sampling reflex in maintaining continence, however, remains unclear. In children who have undergone colonic pull-through surgery, see Chapter 117, some degree of sensory discrimination is preserved. 72 Because the anal mucosal sensory zone is absent in these children, the suggestion has been made that sensory receptors, possibly located in the puborectalis muscle, may play a role in facilitating sensory discrimination. Traction on the muscle is a potent stimulus for triggering defecation and a sensation of rectal distension. Because abolition of anal sensation by the topical application of 5% lidocaine does not reduce resting sphincter pressure, it affects voluntary squeeze pressure but does not affect the ability to retain saline infused into the rectum. The role of anal sensation in maintaining fecal continence has been questioned. 19 Dyssynergic defecation and incomplete stool evacuation in some patients, particularly older adults, prolonged retention of stool in the rectum or incomplete evacuation may lead to seepage of stool or staining of undergarments. 73 Most of these patients show obstructive or dyssynergic defecation. 74 And many of them also exhibit impaired rectal sensation, whereby anal sphincter and pudendal nerve function is intact but the ability to evacuate a simulated stool is impaired. Similarly, in older adults and in children with functional incontinence, prolonged retention of stool in the rectum can lead to fecal impaction, which may also cause prolonged relaxation of the IAS, thereby allowing liquid stool to flow around impacted stool and escape through the anal canal. See Chapter 19.70 Descending perineum syndrome in women with long-standing constipation and a history of excessive straining for many years, perhaps even without prior childbirth. Excessive straining may lead to progressive denervation of the pelvic floor muscles. 75 Most of these patients demonstrate excessive perineal descent and sphincter weakness that may lead to rectal prolapse, but fecal incontinence is not an inevitable consequence. Whether or not incontinence develops will depend on the state of the pelvic floor and the strength of the sphincter muscles. Altered stool characteristics: the consistency, volume, and frequency of stool and the presence or absence of irritants in stool may also contribute to the pathogenesis of fecal incontinence. 2 In the presence of large volume liquid stools, which often transit the hindgut rapidly, continence can only be maintained through intact sensation and a strong sphincteric barrier. In patients with bile salt malabsorption, lactose or fructose intolerance, or rapid dumping of osmotic material into the colon, colonic transit of gaseous and stool contents is too rapid and can overwhelm the continence mechanisms. See Chapters 16 and 104. 2 Miscellaneous mechanisms: various medical conditions and disabilities may predispose to fecal incontinence, particularly in older adults. Immobility and lack of access to toileting facilities are primary causes of fecal incontinence in this population. 76 Several drugs may inhibit sphincter tone. Some are used to treat urinary incontinence and detrusor instability, including anticholinergics like tolterodine tartrate, Detrol, and oxybutynin, e.g., ditropan, and muscle relaxants like baclofen, e.g., Lyresil, and cyclobenzaprine, e.g., Flexeril. Stimulants, e.g., caffeinated products, fiber supplements, laxatives, produce fecal incontinence by causing diarrhea. 19 Box 181 Features of the history that should be elicited from a patient with fecal incontinence: onset and precipitating event, duration and timing, severity, stool consistency and rectal urgency, history of fecal impaction, coexisting problems, e.g., diarrhea, IBD, drugs, caffeine, diet, past history, spine surgery, urinary incontinence, back injury, diabetes mellitus. Neurologic disorders, clinical subtypes, passive or urge incontinence or fecal seepage, obstetric history, use of forceps, tears, presentation of the infant, repairs, evaluation history. The first step in evaluating a patient with fecal incontinence is to establish a trusting relationship and assess the duration and nature of the symptoms, with specific attention to 1. Whether the leakage consists of flatus, liquid stool, or solid stool, and 2. The impact of the symptoms on QOL, Box 18.1. Because many people misinterpret fecal incontinence as diarrhea or urgency. 77 A detailed characterization of the complaint is important. The clinician should ask about the use of pads or other devices and the patient's ability to discriminate between formed or unformed stool and gas. Lack of such discrimination is termed rectal agnosia. 2 An obstetric history, dietary history, and history of coexisting urinary incontinence and conditions like diabetes mellitus, pelvic radiation, neurologic problems, or spinal cord injury are important. A prospective stool diary, specifically the FiStool smartphone application, can be useful. The circumstances under which incontinence occurs should also be determined. Such a detailed inquiry may facilitate recognition of the following types of fecal incontinence: passive incontinence, the involuntary discharge of fecal matter or flatus without any awareness. This pattern suggests a loss of perception or impaired rectoanal reflexes, with or without sphincter dysfunction. Urge incontinence, the discharge of fecal matter or flatus despite active attempts to retain these contents. Predominant causes of this pattern are disruption of sphincter function and a decrease in rectal capacity to retain stool. Fecal seepage, the undesired leakage of stool, often after a bowel movement, with otherwise normal continence and evacuation. This condition results primarily from incomplete evacuation of stool or impaired rectal sensation. 73,74 Sphincter function and pudendal nerve function are mostly intact. Although overlap exists among the three types, useful insights can be gained regarding the underlying mechanism, and preferred management by determining the predominant pattern. Symptom assessment may not correlate well with manometric findings, see later. In one study, leakage had a sensitivity of 98.9%, specificity of 11%, and positive predictive value of 51% for detecting a low resting anal sphincter pressure on manometry. 78 The positive predictive value for detecting a low anal squeeze pressure was 80%. Therefore, for an individual patient with fecal incontinence, the history and clinical features alone are insufficient to define the pathophysiology, and objective testing is essential, see later. 79,80 A number of self-reporting QOL and fecal incontinence severity scales are available that have been validated, including FI-QOL, fecal incontinence QOL, St. Mark's/VIZ score 81 FISI, fecal incontinence severity index, 82 FIS, fecal incontinence severity score, 12,83 and ICIQB. International Consultation on Incontinence Questionnaire Bowels, 0.84 On the basis of the clinical features, several grading systems have been proposed. A modification of the Cleveland Clinic Grading System 85 has been validated by investigators at St. Mark's Hospital 81 and provides an objective method of quantifying the degree of incontinence. It can also be useful for assessing the efficacy of therapy. This grading system is based on 7 parameters: the character of the anal discharge as 1. Solid, 2. Liquid, or 3. Flatus, 4. The degree of alterations in lifestyle, the need to 5. Wear a pad or 6. Take antidiarrheal medication, and 7. The ability to defer defecation. The total score ranges from 0, continent, to 24, severe incontinence. As noted earlier, however, clinical features alone are insufficient to define the pathophysiology. The use of validated questionnaires such as the Symptom Checklist 90R, SCL 90R, and Short Form 36, SF 36, and FI-QOL surveys may provide additional information regarding psychosocial issues and the impact of fecal incontinence on the patient's QOL. However, a stool diary that prospectively records key symptoms associated with fecal incontinence can provide useful perspectives on the problem and can also be used for the assessment of the percentage of bowel movements that are associated with fecal incontinence, a key parameter for the evaluation of treatment success. 86 An electronic stool diary using a smartphone application, FI-Stool app, is available for recording bowel symptoms and could prove extremely useful. Physical examination. A detailed physical examination, including a neurologic examination, should be performed in any patient with fecal incontinence because incontinence may be secondary to a systemic or neurologic disorder. A stepwise approach for performing a digital rectal examination in a patient with suspected fecal incontinence and documentation and scoring of the abnormal examination findings has been described. 87 The focus of the examination is on the perineum and anorectum. Perineal inspection and digital rectal examination are best performed with the patient lying in the left lateral position and with good illumination. On inspection, the presence of fecal matter, prolapsed hemorrhoids, dermatitis, scars, skin excoriations, or a gaping anus and the absence of perianal creases may be noted. These features suggest sphincter weakness or chronic skin irritation and provide clues regarding the underlying cause. 2 Excessive perineal descent or rectal prolapse can be demonstrated by asking the patient to attempt defecation. An outward bulge that exceeds 3 cm is usually defined as excessive perineal descent, see Chapter 19.88. First, perianal sensation should be checked. The anocutaneous reflex examines the integrity of the connections between the sensory nerves and skin, the intermediate neurons and spinal cord segments S2, S3, and S4, and the motor innervation of the EAS. This reflex can be assessed by gently stroking the perianal skin in each perianal quadrant with a cotton bud. A normal response consists of a brisk contraction of the EAS, anal wink. An impaired or absent anocutaneous reflex suggests either afferent or efferent neuronal injury. 2 After inserting a lubricated, gloved index finger into the anus and rectum, the clinician should assess the resting sphincter tone, length of the anal canal, strength of the puborectalis sling, acuteness of the anorectal angle, strength of anal sphincter squeeze, and elevation of the perineum during voluntary squeeze. The presence of a rectocele or impacted stool may be noted. The accuracy of the digital rectal examination has been assessed in several studies. In one study of 66 patients, digital rectal examination by an experienced surgeon correlated somewhat with resting sphincter pressure, R equals 0.56, P 0.001, or maximum squeeze pressure, R equals 0.72, P 0.001, 0.89 in a study of 280 patients with various anorectal disorders. A reasonable correlation was reported between digital examination and manometric findings, but the sensitivity, specificity, and positive predictive values of digital examination were low. 0.90 in another study of 64 patients. Correlations between digital rectal examination with resting and squeeze pressure were 0.41 and 0.52, respectively. 0.91 These data suggest that digital rectal examination provides only an approximation of sphincter strength. The findings are influenced by many factors, including the size of the examiner's finger, technique used, and cooperation of the patient. Moreover, trainees lack adequate skills for recognizing the features of fecal incontinence on digital rectal examination. 0.92 Although digital rectal examination can identify patients with fecal impaction and overflow, it is not accurate for diagnosing sphincter dysfunction and should not be used as the basis for decisions regarding treatment. 0.2 Diagnostic testing. An important step in assessing a patient with fecal incontinence is to determine whether the incontinence is secondary to diarrhea or independent of stool consistency. If diarrhea coexists with incontinence, appropriate tests should be performed to identify the cause of the diarrhea. See Chapter 16. Such testing may include flexible sigmoidoscopy or colonoscopy to exclude colonic mucosal inflammation, a rectal mass or stricture, and stool studies for infection, volume, osmolality, electrolytes, fat content, and pancreatic dysfunction. Biochemical tests should be performed to look for thyroid dysfunction, diabetes mellitus, and other metabolic disorders. Breath tests may be considered for lactose or fructose intolerance or SIBO. 0.2 A history of cholecystectomy may suggest bile salt malabsorption and prompt a therapeutic trial of a bile salt binding agent. Specific tests are available for defining the underlying mechanisms of fecal incontinence and are often used in a complementary fashion. The most useful tests are anorectal manometry, anal endosonography, the balloon expulsion test, BET, special neurophysiologic tests including translumbosacral anorectal magnetic stimulation, TEMS, and PNTML 2,93-96, as well as newer tests such as the anorectal endoluminal functional lumen imaging probe, EndoFlip, for defining the anal sphincteric region. 0.97 Anorectal manometry. Anorectal manometry is a useful method for assessing IAS and EAS pressures, Fig 18.3, as well as rectal sensation, rectoanal reflexes, and rectal compliance. Several types of probes and pressure recording devices are available. Each system has distinct advantages and drawbacks. However, an international survey of experts showed significant variability in methodology, performance characteristics, and interpretation of the tests. 0.98 Although traditionally a water-perfused probe with closely spaced sensors has been used, too increasingly, solid-state probes with microtransducers or air-filled miniaturized balloons are being adopted globally. A solid-state probe with 12 circumferential sensors spaced at 1 cm intervals with a 4.2 mm outer diameter and 4 cm long balloon, given imaging, provides high resolution. 0.99 This device uses a novel pressure transduction technology, TACT array, that allows each of the pressure sensing elements to detect pressure over a length of 2.5 mm and in each of 12 radially dispersed sectors. The data can be displayed in isobaric contour plots that can provide a continuous dynamic representation of pressure changes, although anal sphincter pressures are higher than those recorded with water-perfused manometry. A high-definition 3D manometry system with 256 circumferentially arrayed sensors in a 5 cm probe is also being used in many laboratories and provides anal sphincter pressure profiles and topography. Fig 18.4. The anal endoflip is a newer system that is composed of a probe with a balloon housing multiple impedance sensors and provides a 3D profile of the anal high-pressure zone. Quantification of time. Fig 18.3. Anorectal manometry profiles in a healthy normal subject in whom squeeze, external anal sphincter, and resting, internal anal sphincter, pressures are normal, and b. a patient with fecal incontinence in whom squeeze and resting pressures are weak. Upper tracings, rectal pressure activity, middle tracings, anal pressure activity at 2.5 cm, lower tracings, anal pressure activity at 1 cm from the anal margin. The anal sphincter distensibility index, and an assessment of anal resistance, opening forces, and compliance. Fig 18.5.97. Further studies are required to assess its clinical utility. Anal sphincter pressures can be measured by stationary or station pull-through techniques. 85,94. Resting anal sphincter pressure predominantly represents IAS function, and voluntary anal squeeze pressure represents EAS and puborectalis function. Patients with fecal incontinence have low resting and low squeeze pressures, see Figs 18.3 and 18.4, indicating IAS and EAS weakness, respectively. 2,90. The duration of sustained squeeze pressure. Posterior anterior low pressure area 3D, sagittal view 2D, unfolded view. Fig 18.4. High definition anal sphincter vector topography showing pressure changes during maximal squeeze in a 3-dimensional sagittal view, left, and a 2-dimensional unfolded view, right. A. Changes in a healthy control subject. B. Changes in a subject with fecal incontinence. The subject with incontinence has significant anal sphincter weakness, with an asymmetrical squeeze and a change in some vectors, predominantly yellow and green, whereas the healthy subject shows a robust squeeze, orange and red, and symmetrical decrease in sphincter diameter. Provides an index of sphincter muscle fatigue. The ability of the EAS to contract reflexively can be assessed during abrupt increases in intra-abdominal pressure, as when the patient coughs. This reflex response causes the anal sphincter pressure to rise above that of the rectal pressure to preserve continence. The response may be triggered by receptors in the pelvic floor and mediated through a spinal reflex arc. In patients with a spinal cord lesion above the conus medullaris, this reflex response is preserved even though voluntary squeeze may be absent, whereas in patients with a lesion of the cauda equina or sacral plexus, both the reflex and voluntary squeeze responses are absent. 2,100,101. Anorectal manometry can provide useful information regarding anorectal function. 93,95,102. The American Motility Society has recommended guidelines and minimal standards for manometry testing. 95. Although data regarding normal values are insufficient, and results between healthy subjects and patients with fecal incontinence overlap. 90. With large confidence intervals for test reproducibility. 103. Manometry testing can be useful in an individual patient with fecal incontinence. 95. Manometric tests of anorectal function may also be useful for assessing objective improvement following drug therapy, biofeedback therapy, or surgery. See later. 104-106. International efforts to develop consensus among experts regarding testing methodology and interpretation of tests could pave the way for standardizing the test and improving clinical diagnosis and patient management. 98. Rectal sensory testing. Rectal balloon distension with air or water can be used to assess sensory responses and compliance of the rectal wall. By Fig 18.5. Anorectal endoluminal functional lumen imaging probe, endoflip. Topographic profiles in a healthy subject showing a normal high-pressure zone profile, cross-sectional area and distensibility index at rest, left panel, and during squeeze, right panel, and b. a patient with fecal incontinence. When measured at 50 ml balloon distension, the anal distensibility index in the patient with fecal incontinence at rest, 5.5 mm 2/mmHg, was significantly higher than that of the healthy subject, 0.6 mm 2/mmHg, suggesting a weak and easily distensible anal sphincter. Also during squeeze, the distensibility index was significantly higher in the patient with fecal incontinence, 2.5 mm 2/mmHg, than that of the healthy subject, 0.2 mm 2/mmHg. Fig 18.6 Anal endosonograms. A. Normal, healthy subject with an intact hypoechoic internal anal sphincter, IAS, and an intact thicker and hyperechoic external anal sphincter, EAS. B. Subject with fecal incontinence secondary to an obstetric injury, causing a large anterior sphincter defect that involves the IAS and EAS and spans the circumference between the 10 and 2 o'clock positions, arrows. Distending a balloon with incremental volumes in the rectum, the thresholds for first perception, first desire to defecate, and urgent desire to defecate can be assessed. A higher threshold for sensory perception indicates rectal hyposensitivity 0.2,100,107. The balloon volume required for partial or complete inhibition of anal sphincter tone can also be assessed. The volume required to induce reflex anal relaxation is lower in incontinent patients than in controls 0.108 because sampling of rectal contents by the anal mucosa may play an important role in maintaining continence. 37 Quantitative assessment of anal perception using electrical or thermal stimulation has been advocated but is not used clinically. 2 Rectal compliance can be calculated by assessing the changes in rectal pressure during balloon distension with air or fluid. 94,109 Rectal compliance is reduced in patients with colitis, 66 patients with a low spinal cord lesion, and diabetic patients with incontinence but is increased in those with a high spinal cord lesion. Imaging the anal canal. Anal endosonography. Anal endosonography is performed by using a 7 to 15 MHz rotating transducer with a focal length of 1 to 4 cm. 110. The test provides an assessment of EAS and IAS thickness and structural integrity and can detect scarring, loss of muscle tissue, and other local pathology. Fig 18.6, 0.111 Higher frequency, 10 to 15 MHz, probes and 3D reconstruction of the anal sphincter that provide improved delineation of the sphincter complex have become available. 111. After vaginal delivery, anal endosonography has revealed occult sphincter injury in 35% of primiparous women. Most of these lesions were not detected clinically. In another study, sphincter defects were detected in 85% of women with a third-degree perineal tear, compared with 33% of patients without a tear. 112 In studies that compared EMG, see later, mapping with anal endosonography, the concordance rate for identifying a sphincter defect was high, 113,114, but the technique is operator-dependent and requires training and experience. 94 Although endosonography can distinguish internal from external sphincter injury, it has a low specificity for demonstrating the cause of fecal incontinence. 2 Because anal endosonography is more widely available, less expensive, and certainly less painful than EMG, which requires needle insertion, it is the preferred technique for examining the morphology of the anal sphincter muscles and detecting anal sphincter defects. 98 MRI. Endoanal MRI can provide superior imaging with excellent spatial resolution, particularly for defining the anatomy of the EAS. 115,116 One study 117 but not another 115 has shown that MRI is less accurate than anal endosonography. A major contribution of anal MRI has been the recognition of EAS atrophy, which may adversely affect sphincter repair. See later. 118. Atrophy may be present without pudendal neuropathy. 119 The addition of dynamic pelvic MRI using fast imaging sequences or MRI colpocystography, which involves filling the rectum with ultrasound gel as a contact agent and having the patient evacuate while lying inside the magnet, may define the anorectal anatomy more precisely. 120 Use of an endoanal coil enhances resolution and allows more precise definition of the sphincter muscles. Comparative studies of costs, availability, technical factors, clinical utility, and role in treatment decision-making are warranted. Defecography uses fluoroscopic techniques to provide morphologic information about the rectum and anal canal. 121 It is used to assess the anorectal angle, measure pelvic floor descent and the length of the anal canal, and detect the presence of a rectocele, rectal prolapse, or mucosal intussusception. About 150 ml of contrast material is placed into the rectum, and the subject is asked to squeeze or cough and expel the contrast. Although defecography can detect a number of abnormalities, these findings can also be seen in otherwise asymptomatic persons 94,122 and their presence correlates poorly with impaired rectal evacuation. Agreement between observers in the measurement of the anorectal angle is also poor. Whether one should use the central axis of the rectum or the posterior wall of the rectum when measuring the angle is unclear. The functional significance of identifying morphologic defects has been questioned. Although defecography can confirm the occurrence of incontinence at rest or during coughing, it is most useful for demonstrating rectal prolapse 2,123 or poor rectal evacuation, see Chapter 19. In selected patients, magnetic resonance defecography can be used to evaluate evacuation and identify coexisting problems, e.g., rectocele, enterocele, cystocele, mucosal intussusception. 111 Balloon expulsion test. Normal patients can expel a 50 ml water-filled balloon 124 or a silicone-filled artificial stool from the rectum in less than 1 minute. 2 Some studies have used a Foley balloon for performing this test 125, however, one study has shown that use of a Foley balloon is an inappropriate method, and up to 50% of normal subjects may experience difficulty expelling this device. 126 Most patients with fecal incontinence have little or no difficulty with evacuation, but patients with fecal seepage 74 and many older persons with fecal incontinence secondary to fecal impaction 73 demonstrate impaired evacuation. In these patients, a bed may help identify coexisting dyssynergia or a lack of coordination between the abdominal, pelvic floor, and anal sphincter muscles during defecation. One study has shown a high frequency of dyssynergia in residents of nursing homes, see Chapter 19. 127 Neurophysiologic testing. EMG of the muscle activity from the anal sphincter is a useful technique for identifying sphincter injury as well as denervation-renervation potentials that can indicate neuropathy. 30 EMG can be performed using a fine wire needle electrode or a surface electrode, such as an anal plug. Abnormal EMG activity like fibrillation potentials and high-frequency spontaneous discharges provides evidence of chronic denervation, which is commonly seen in patients with fecal incontinence secondary to pudendal nerve injury or cauda equina syndrome. 128 The PNTML measures neuromuscular integrity between the terminal portion of the pudendal nerve and the anal sphincter. Injury to the pudendal nerve leads to denervation of the anal sphincter muscle and muscle weakness. Therefore, measurement of the nerve latency time can help distinguish muscle injury from nerve injury as the cause of a weak sphincter muscle. A disposable electrode, St. Mark's electrode Dantak, Denmark, is used to measure the latency time. 129 Prolonged nerve latency time suggests pudendal neuropathy. Women who have delivered vaginally with a prolonged second stage of labor or have had forceps-assisted delivery have been found to have a prolonged PNTML compared with women who delivered by cesarean section or spontaneously. 131 An American Gastroenterological Association technical review did not recommend PNTML 94, although an expert review has noted that patients with pudendal neuropathy generally have a poor surgical outcome. 132 A normal PNTML does not exclude pudendal neuropathy, because the presence of a few intact nerve fibers can lead to a normal result, whereas an abnormal latency time is significant. PNTML may be useful for the assessment of patients prior to anal sphincter repair and is particularly helpful in predicting surgical outcome. The integrity of the peripheral component of efferent motor pathways that control anorectal function can also be assessed by recording the motor evoked potentials, MEPS, of the rectum and anal sphincter in response to magnetic stimulation of the lumbar and sacral nerve roots, using a novel non-invasive modality TAMS bilaterally. 25-35-36 The technique is based on Faraday's principle, which states that in the presence of a changing electrical field, a magnetic field is generated. Consequently, when a current is discharged rapidly through a conducting coil, a magnetic flux is produced around the coil. The magnetic flux causes stimulation of neural tissue. TAMS allows more precise localization of the nerve pathways between the spinal cord and the anal sphincter, as well as subcomponent analysis of the efferent peripheral nervous system, rectum, and anal sphincter. Electrical or magnetic stimulation of the lumbosacral nerve roots facilitates measurement of the conduction time within the cauda equina and can diagnose sacral motor radiculopathy as a possible cause of fecal incontinence. 133,134 One study has shown that recording of translumbar MEPS and transsacral MEPS of the rectum and anus provides delineation of peripheral neuromuscular injury in patients with fecal incontinence, Fig 18.7. 36 and can reveal hitherto undetected changes in patients with back injury. Another study assessed the locus of efferent in patients with fecal incontinence and showed that although the transcranial anorectal MEPS were prolonged in patients with fecal incontinence when compared with healthy controls, the primary locus for nerve dysfunction in patients with fecal incontinence was between the spinal nerve roots and the anorectum. The segment between the brain and spinal cord was mostly intact. 32 Clinical utility of tests for fecal incontinence. Fig 18.7 Equipment for the translumbosacral anorectal magnetic stimulation, TAMS, test, left, and anal motor evoked potential, MEP, responses following translumbar magnetic stimulation, right. The equipment consists of a magnetic stimulation device, a magnetic coil, and an anorectal MEP probe. The subject's position is illustrated at the bottom left. The MEP response from a healthy subject, top right, shows a normal MEP latency of 2.94 milliseconds. The lower right profile from a patient with fecal incontinence shows a prolonged latency and a smaller amplitude of the MEP response, indicating anorectal neuropathy. In one prospective study, history taking alone could detect an underlying cause in only 9 of 80 patients, 11%, with fecal incontinence, whereas physiologic tests revealed an abnormality in 44 patients, 55%. 135 In a large retrospective study of 302 patients with fecal incontinence, an underlying pathophysiologic abnormality was identified, but only after manometry, EMG, and rectal sensory testing were performed. 136 Most patients had more than one pathophysiologic abnormality. In another large study of 350 patients, incontinent patients had lower resting and squeeze sphincter pressures, a smaller rectal capacity, and earlier leakage following saline infusion in the rectum. 102 Nevertheless, results of a single test or a combination of 3 different tests, anal manometry, rectal capacity, saline continence test, provided a low discriminatory value between continent and incontinent patients. This finding emphasizes the wide range of normal values and the ability of the body to compensate for the loss of any one mechanism involved in fecal incontinence. In a prospective study, anorectal manometry with sensory testing not only confirmed a clinical impression but also provided new information that was not detected clinically. 93 Diagnostic information obtained from these studies can influence both management and outcomes of patients with incontinence. A single abnormality was found in 20% of patients, whereas more than one abnormality was found in 80% of patients. In another study, abnormal sphincter pressure was found in 40 patients, 71%, and altered rectal sensation or poor rectal compliance was present in 42 patients, 75%. 135 These findings were confirmed by another study, which showed that physiologic tests provided a definitive diagnosis in 66% of patients with fecal incontinence. 136 Still, on the basis of the test results alone, it is not possible to predict whether an individual patient is continent or incontinent. An abnormal test result must be interpreted in the context of the patient's symptoms and the results of other complementary tests. Tests of anorectal function provide objective data and define the underlying pathophysiology. Table 18.2 summarizes the key tests, information gained from them, and evidence to support their clinical use. Treatment goals for patients with fecal incontinence are to restore continence and improve QOL. Strategies that include supportive and specific measures may be used. An algorithmic approach to the evaluation and management of patients with fecal incontinence is presented in Fig 18.8. Supportive measures like avoiding offending foods, ritualizing bowel habits, improving skin hygiene, and instituting lifestyle changes may serve as useful adjuncts to managing fecal incontinence. For older or institutionalized patients with fecal incontinence, the availability of personnel experienced in the treatment of fecal incontinence, timely recognition of soiling, and immediate cleansing of the perianal skin are of paramount importance. 76 Hygienic measures such as changing undergarments, cleaning the perianal skin immediately following a soiling episode, using moist wipes rather than dry toilet paper, and using barrier creams like zinc oxide and calamine lotion, calmiceptin. Calmiceptin, Huntington Beach, CA, may help prevent or heal skin excoriation. Perianal fungal infections should be treated with topical antifungal agents. More importantly, scheduled toileting with a commode at the bedside, or bedpan, and supportive measures to improve the patient's general well-being and nutritional status may prove effective. Stool deodorants, e.g., Bedside Care Perineal Wash Coloplast Manufacturing, North Mankato, MN, Durafil Integra, Plainsboro, New Jersey, Devrom Parthenon, Salt Lake City, UT, can help disguise the smell of feces. In an institutionalized patient, ritualizing the bowel habit and instituting cognitive training may prove beneficial. Using these measures, short-term, 3 to 6 month, success rates of up to 60% have been reported in case series. 137 Patients in whom these measures fail have been shown to have a higher mortality rate than those without incontinence and those with incontinence who respond to these measures. 138 Other supportive measures include dietary modifications like reducing caffeine or fiber intake. Caffeinated coffee enhances the gastrocolic, or gastroileal, reflex, increases colonic motility. 139 and induces fluid secretion in the small intestine. 140 Reducing caffeine consumption, particularly after meals, may help lessen postprandial urgency and diarrhea. Brisk physical activity, particularly after meals or immediately after waking, may precipitate fecal incontinence, because these physiologic events are associated with increased colonic motility. 141 and enhanced colonic transit. 142 In a study of 2,565 adults that monitored exercise activity and fecal incontinence, after adjustments, fecal incontinence was positively associated with moderate to vigorous exercise but not with light-intensity physical activity. 143 A food and symptom diary may identify dietary factors that cause diarrheal stools and Table 18.2 Diagnostic tests for fecal incontinence * clinical use quality of test advantages disadvantages evidence comments physiology anorectal manometry, high quantifies normal or weak EAS and IAS and lack of standardization good useful for detecting anal resolution and 3D high puborectalis pressures, identifies rectal sphincter weakness, definition, hyposensitivity, rectal hypersensitivity, impaired altered rectal sensation rectal compliance dyssynergic defecation and accommodation, and dyssynergia anorectal endoflip measures the cross-sectional area of the anal lack of normative data fair mostly used in research labs, sphincter distensibility index and sphincter and availability clinical utility not fully known compliance needle EMG quantifies spike potentials and reinnervation invasive, painful, not fair useful but used largely in pattern indicating neuropathy or myopathy widely. Available research laboratories surface EMG displays EMG activity, can provide information on inaccurate, frequent fair used largely for neuromuscular normal or weak muscle tone artifacts training pudendal nerve terminal measures latency of the terminal portion of the minimally invasive, low fair conflicting data, correlation motor latency, PNTML, pudendal nerve, simple to perform sensitivity, interobserver with other tests and surgical differences outcome unclear translumbosacral. Anorectal quantifies the nerve conduction time of the entire lack of training and good non-invasive test, objective and magnetic stimulation spinoanal and spinorectal pathways, minimally availability higher yield than PNTML, TAMS, test invasive quantifies anal and rectal neuropathy colonic transit study with evaluates the presence of fecal retention, inconsistent methodology, good useful for identifying patients radiopaque markers inexpensive and widely available validity has been with fecal seepage and older questioned persons with impaction balloon expulsion test, BET, simple, inexpensive, bedside assessment of lack of standardization. Good normal BET does not exclude ability to expel a simulated stool, identifies dyssynergia, should be dyssynergic defecation interpreted in the context of other anorectal test results. Imaging anorectal US visualizes IAS and EAS defects, thickness, and interobserver bias, scars. Good most widely available test atrophy and puborectalis muscles difficult to identify. Defecography detects prolapse, intussusception, obtuse radiation exposure, fair useful and complementary anorectal angle, and pelvic floor weakness, as embarrassment, with other tests well as rectoceles and megarectum availability. Interobserver bias, inconsistent methodology. MRI simultaneously evaluates global pelvic floor. Expensive, lack of fair use as an adjunct to other anatomy and dynamic motion, reveals standardization and tests. Sphincter morphology and pathology outside availability. The anorectum plain abdominal film identifies excessive amount of stool in the colon, lack of standardization of pore. Not recommended for routine. Simple, inexpensive, widely available interpretation, lack of evaluation but useful in controlled studies. Older adults and children with incontinence and fecal impaction. Barium enema identifies megacolon, megarectum, stenosis, lack of standardization, pore. Not recommended as part of diverticulosis, extrinsic compression and embarrassment. Routine evaluation. Intraluminal masses. Radiation exposure, lack of controlled studies. Endoscopy. Flexible sigmoidoscopy and directly visualizes the colon to exclude mucosal invasive risks related to pore indicated in patients with colonoscopy lesions, e.g., solitary rectal ulcer syndrome. Procedure: perforation, unexplained diarrhea and inflammation, malignancy, bleeding, and sedation. Seepage and patient's age 53D. 3-dimensional, EAS, external anal sphincter, endoflip, endoluminal functional lumen imaging probe, IAS, internal anal sphincter. Asterisk evidence-based summary. Incontinence. Frequent culprits are lactose and fructose, which may be malabsorbed. 144. Eliminating food items containing these constituents may prove beneficial. 2. Fiber supplements such as psyllium are often advocated in an attempt to increase stool bulk and reduce watery stools. In a single case controlled study, psyllium led to modest improvement. 145. But fiber supplements can potentially worsen diarrhea by increasing colonic fermentation of unabsorbable fiber. Specific therapies. Pharmacologic therapy. The antidiarrheal agents loperamide hydrochloride, Imodium, and diphenoxylate and atropine sulfate, Lomotil, remain the mainstays of drug treatment for fecal incontinence, although other drug treatments have been proposed. 2,146 In placebo-controlled studies, loperamide, 4 mg 3 times daily, has been shown to reduce the frequency of incontinence, improve stool urgency, and increase colonic transit time. 104 As well as increase anal resting sphincter pressure. 147 And reduce stool weight. An 8-week randomized crossover study of 80 patients with fecal incontinence showed an approximate 40% reduction in fecal incontinence episodes with both loperamide and psyllium, but there was no difference between the two treatments. 148 Clinical improvement was also reported with diphenoxylate and atropine. 149 But objective testing showed no improvement in the patient's ability to retain saline or spheres in the rectum. Although most patients temporarily benefit from antidiarrheal agents, many report cramping, lower abdominal pain, or difficulty with evacuation after a few days. Careful dose titration is required to produce the desired result. Another randomized controlled study tested clonidine, an alpha-2 adrenergic agonist, 0.1 mg twice daily, in patients with incontinence and found that, although diarrhea decreased, the number of episodes of fecal incontinence did not change. 150 Idiopathic bile salt malabsorption may be an important underlying cause of diarrhea and fecal incontinence, see chapters 16 and 64. 151 Patients with this problem may benefit from titrated doses of ion exchange resins like cholestyramine, Caestran, 2 to 6 grams daily, Cholestipol, Cholestid, or Colsavilum, Welchol. Alostrin, Latrinex, a 5-hydroxytryptamine 3 receptor antagonist approved for treatment of IBS and diarrhea, may serve as an adjunctive therapy for fecal incontinence, but the drug's side effects restrict its use. See Chapter 122. 152 Postmenopausal women with fecal incontinence may benefit from estrogen replacement therapy. 153 An open-label study has shown that oral amitriptyline, 20 mg, is useful in treating patients who have urinary or fecal incontinence without evidence of a structural defect or neuropathy. 154 Suppositories or enemas may also have a role in the treatment of incontinent patients with incomplete rectal evacuation or in those with post-defecation seepage. In some patients, constipating medications alternating with periodic enemas may provide more controlled evacuation of bowel contents, but these interventions have not been tested prospectively. 14 hours and 9 minutes 9 hours and 20 minutes A time B time Fig 18.9 Anal manometric pressure tracings in a patient with fecal incontinence before, A, and after, B, neuromuscular training, biofeedback, while squeezing and at rest. Before neuromuscular training, the patient has a weak and poorly sustained squeeze and makes multiple ineffective attempts to squeeze. After 6 sessions of training, the patient's ability to generate and sustain the squeeze has improved significantly. Biofeedback neuromuscular and sensory training, usually referred to as biofeedback therapy, or simply biofeedback, improves symptoms of fecal incontinence, restores QOL, and improves objective parameters of anorectal function. Biofeedback training is useful in patients with a weak sphincter or impaired rectal sensation. The method is based on operant conditioning techniques whereby an individual acquires a new behavior through a learning process of repeated reinforcement and instant feedback. 2,155 The goals of biofeedback therapy in a patient with fecal incontinence are 2. 1. Improve anal sphincter muscle strength. 2. Improve coordination between the abdominal, gluteal, and anal sphincter muscles during voluntary squeeze and following rectal perception, and 3. Enhance anorectal sensory perception. Because each goal requires a specific method of training, the treatment protocol should be customized for each patient on the basis of the underlying pathophysiologic mechanism. Biofeedback training is often performed using visual, auditory, or verbal feedback techniques, and the feedback is provided via a manometry or EMG probe placed in the anorectum. 2,155 When a patient is asked to squeeze, the anal sphincter contraction is displayed as an increase in anal pressure or EMG activity. This visual cue provides instant feedback to the patient. The aim of recto-anal coordination training is to achieve a maximum voluntary squeeze in less than 2 seconds after a balloon is inflated in the rectum. In reality, this maneuver mimics the arrival of stool in the rectum and prepares the patient to react appropriately by contracting the right group of muscles. 2,155 Patients are taught how to squeeze their anal muscles selectively without increasing intra-abdominal pressure or inappropriately contracting their gluteal or thigh muscles. This maneuver also identifies sensory delay and trains the individual to use visual clues to improve sensory-motor coordination. 156,157 Sensory training of the rectum educates the patient to perceive a lower volume of balloon distension but with the same intensity as they had felt earlier with a higher volume. This goal is achieved by inflating and deflating a balloon in the rectum repeatedly. These neuromuscular training techniques must be used together with pelvic muscle strengthening, modified Kegel exercises, and other supportive measures to achieve sustained improvement in bowel function. A component analysis muscle training, sensory training, or both is most effective. Whether Kegel exercises alone are more effective than multiple approaches has not been determined. Predicting how many biofeedback treatment sessions will be required is often difficult. Most patients seem to require between 4 and 6 training sessions. Fig 18.9. 2,105,155 Studies that used a fixed number of treatment sessions, often fewer than 3, showed a less favorable improvement response than those that titrated the number of sessions on the basis of the patient's performance. 158,159 In one study, periodic reinforcement with biofeedback training at 6 weeks, 3 months, and 6 months was thought to confer additional benefit. 105 and long-term improvement. 160 In the literature on fecal incontinence 161-171 the terms improvement, success, and cure have been used interchangeably, and the definition of each term has been inconsistent. In uncontrolled studies, subjective improvement has been reported in 40% to 85% of patients. 2,158 Table 18.3 summarizes selected randomized controlled trials of biofeedback therapy in patients with fecal incontinence. 155, 156, 162, 163, 167-170. A Cochrane review of 11 randomized controlled trials concluded that no method of training is better than any other method. 172 Whether biofeedback is superior to conservative management is also unclear. In a randomized controlled trial 108 patients were randomized to receive either 6 sessions of EMG biofeedback, n equals 44, or Kegel exercises, n equals 64, plus supportive therapy. After treatment, 77% of patients who received biofeedback reported adequate relief of symptoms compared with 41% of those who did Kegel exercises, p. 0.001. The number of episodes of incontinence was not different between groups in an intention to treat analysis, but a trend toward improvement, p equals 0.042, was observed in a per-protocol analysis. 163 This study suggests that biofeedback is superior to Kegel exercises. Another randomized controlled trial compared sustained squeeze with rapid and sustained squeeze and found improvement in continence in 86% of patients but no difference between the two groups. 173 Another study compared biofeedback and medium-frequency electrical stimulation with low-frequency electrical stimulation, see later, and showed that 54% of patients improved following biofeedback plus electrical stimulation compared with electrical stimulation alone. 174 One study compared pelvic floor exercises plus rectal balloon training with pelvic floor exercises alone and showed that incontinence improved in 51% versus 48% of patients, respectively, with no difference between treatments. 175 The technique of biofeedback training has not been standardized, and the use of this treatment is largely restricted to specialized centers. The manometric parameters obtained at baseline do not appear to predict the clinical response to biofeedback treatment. 176 Similarly, the patient's age, presence of sphincter defects, or presence of neuropathy do not predict outcome. 177 Criteria used for selection, motivation of the individual patient, enthusiasm of the therapist, and severity of incontinence each may affect the outcome. 155, 158, 159, 169 Despite lack of a uniform approach and inconsistencies in reported outcomes of randomized controlled trials, biofeedback training seems to confer benefit, see Table 18.3. Biofeedback therapy is recommended for the treatment of fecal incontinence by the American Gastroenterological Association, Act 178 and the American and European Neurogastroenterology and Motility Societies. 179 Therefore, neuromuscular training should be offered to all patients with fecal incontinence who have failed supportive measures and especially to older patients, patients with comorbid illnesses, and those for whom reconstructive surgery is being considered. Severe fecal incontinence, pudendal neuropathy, and an underlying neurologic disorder are associated with a poor Table 18.3 outcome of biofeedback therapy and/or exercises for fecal incontinence in adults. Reference, S. Subjects, F/M, Treatment Control Outcome 156 17/8 Manometric BFB and Rectal Sensory Training Sham Training, Crossover Treatment Improved Symptoms and Coordination Training, Weekly, 4WK, Design, 16240/0 BFB and Electrical Stimulation, Augmented, Vaginal Manometric Grader. Symptom Improvement in Treatment, Weekly, 12WK, Biofeedback Group then Control Group, P0.001, 163/83 25 BFB plus PFMT plus Sensory Training, Biweekly, PFMT treatment improved symptoms more than 12WK, PFMT alone, 77% versus 41%, P equals 0.001, 167/60/0 BFB, weekly, 12WK, plus electrical stimulation BFB NSD between groups 168-49/0 BFB plus home exercises electrical stimulation both groups improved NSD between groups and symptoms and QOL 169-159/12 4 groups, N/A 54% improved in all groups education plus. Advice NSD between groups and symptoms and QOL as per group 1 plus PFMT as per group 2 plus manometric BFB as per group 3 plus home BFB, biweekly, 6 sessions, 3 MO, 171.07/13 3 groups, N/A NSD between groups and symptoms, QOL and PFMT manometry changes PFMT and anal ultrasound BFB PFMT and manometric BFB, monthly, 5 sessions, 173/53/19 sustained squeeze, 5 sessions, 8 WK, rapid and sustained continence improved in 86% squeeze, 5 sessions, NSD between groups 8 WK, 174/65/15 biofeedback and medium. Frequency low frequency electrical anal continence improved 54% in treatment electrical stimulation, twice daily, 6 MO, stimulation, twice daily, group but 0% in control group 6 MO, 175/72/8 PFMT and RBT, twice weekly for 3 WK, PFMT, twice a week for 3 incontinence improved in both groups, 51% and then once a week, 12 sessions, WK, then once a week, treatment group and 48% in control group 12 sessions, NSD between groups 249, 250 26/4 home biofeedback with novel electrical office. Biofeedback with incontinence improved in both groups, rates of stimulation and anal resistance training arm probe, once a response, greater than or equal to 50% reduction in incontinence, once a day, 6 WK, week, 6 WK, events, were 65% in home group and 60% in office group * selected randomized controlled trials. ARM, anorectal manometry, BFB, biofeedback, using EMG probe unless otherwise specified, F, females, M, males, N/A, not applicable, NSD, no significant difference, PFMT, pelvic floor muscle training, QOL, quality of life, RBT, rectal balloon training. Adapted from Norton C. Fecal Incontinence and Biofeedback Therapy. Gastrointestinal Clin North M 2008, 37:587-604. Response to biofeedback therapy. 180-182 One study has suggested that biofeedback training may be most beneficial in patients with urge incontinence. 183 Biofeedback also seems to be useful for patients who have undergone anal sphincteroplasty. 184 Post-anal repair, see later. 185 or low anterior resection. 186 and children who have undergone correction of a congenital anorectal anomaly. 187 Plugs, sphincter bulking agents, and electrical stimulation. Disposable anal plugs have been used to help temporarily occlude the anal canal and prevent stool leakage. 188 Unfortunately, many patients are unable to tolerate prolonged insertion of the device. 189,190 A plug may be useful for patients with impaired anal canal sensation, those with neurologic disease. 191 and those who are institutionalized or immobilized. In some patients with fecal seepage, insertion of an anal plug made of surgical cotton may prove beneficial. 192 A multi-center, prospective, single-arm, non-randomized controlled study assessed a silicone insert, Renew Medical Incorporated, Foster City, CA, in 91 patients with fecal incontinence. A greater than or equal to 50% reduction in fecal incontinence episodes was seen in 62% of the treated patients, who also had a reduction in incontinence severity scores. About 78% of patients who completed 12 weeks of treatment reported extreme satisfaction with the device in preventing stool leakage. 193 A vaginal bowel control system, Eclipse System Pevalon, Table 18.4 Success rates of minimally invasive surgical interventions for fecal incontinence procedure outcome measures success rate, %. Quality of evidence currently available: injection of dextranomer beads 50% improvement in incontinence episodes 52 versus 31, dextranomer vs. FAIR compared with baseline placebo, anal sphincter repair FAIR sacral nerve stimulation good greater than or equal to 75 to 100 dynamic gracilis nea sphincter poor artificial bowel sphincter full continence 50-100 poor understudy radiofrequency therapy, SECA procedure. Improvement in continence by greater than or equal to 50% 84 poor rectal augmentation avoidance of stoma 64 poor * 5-year success rates fall to 50%. Derived from a Cochrane review, but in some cases data were extrapolated from only one study. Based on a systematic review of case series, no comparative studies available. Explantation rates in case series of approximately 50%. Adapted from Gladman Ma. Surgical treatment of patients with constipation and fecal incontinence. Gastrointestinal Clin North M 2008, 37:60525, with permission. Sunnyvale, CA, using an inflatable, self-retaining balloon, akin to a pessary, operates by providing extrinsic compression of the anorectum. 194 in an open-labeled 4-week trial. 61 of 110 patients were successfully fitted with the device, and 79% of this group reported a greater than or equal to 50% reduction in the number of incontinence episodes. 194 with improvement in QOL. Pelvic discomfort or pain, vaginal spotting, and erythema and urinary leakage were the main adverse events. A long-term controlled trial is awaited. Many people with fecal incontinence choose not to wear a pad. Small anal dressings may be useful for minor soiling contained between the buttocks but can become costly if several dressings are needed each day. Diapers are generally thought to be unsatisfactory for providing security or comfort, for skin protection, or for disguising odor. However, the rising global sales and improvement in diaper technology suggest that diapers may be more acceptable than previously appreciated. Bulking the anal sphincter to augment its surface area and thereby provide a better seal for the anal canal has been attempted with a variety of agents, including autologous fat 195 glutaraldehyde treated collagen 196 and synthetic macromolecules. 197 These materials are usually injected submucosally at the site where the sphincter is deficient or circumferentially if the whole muscle is degenerated or fragmented. Studies have shown definite improvement in the short term in patients with passive fecal incontinence. Injection of dextranomer beads above the dentate line has been shown to be superior to placebo injection in a randomized controlled trial of 206 patients. Response was defined as a 50% or more decrease in the number of incontinence episodes compared with baseline, with response rates of 52% with injection of the beads and 31% with placebo. 198 A 36-month long-term efficacy assessment showed that 52.2% of patients reported sustained benefit, greater than or equal to 50% reduction in the number of episodes, and 13.25% reported complete continence. 199 Another injectable bulking agent, polyacrylate polyalcohol, has also been assessed in a prospective uncontrolled trial of 58 patients. The injections were given subcutaneously through the perianal skin into the submucosa of the anorectum, above the dentate line. About 60% of patients were adjudicated as having treatment success, based on 50% improvement in the Cleveland Clinic score for fecal incontinence. 200 Lack of a control group and selection bias are significant limitations of this study. Electrical stimulation of striated muscle at a frequency sufficient to produce a tonic involuntary contraction, usually 30 to 50 Hz, can increase muscle strength, the conduction rate of the pudendal nerve, and the size of motor units, as well as encourage neuronal sprouting and promote local blood flow. 201,202 Stimulation at lower frequencies, 5 to 10 Hz, can modulate autonomic function, including sensation and overactivity. Studies of electrical stimulation for fecal incontinence have been small, uncontrolled, and confounded by the effects of exercise, biofeedback, or other interventions. A Cochrane review of 4 randomized controlled trials with 260 participants concluded that electrical stimulation may have some effect. 2031 study found that anal electrical stimulation with anal biofeedback produces short-term benefits greater than those with biofeedback alone. 162 Whereas another study found no additional benefit to electrical stimulation over exercises and biofeedback alone. 167 Patients have been shown to improve equally with stimulation at 1 and 35 Hz. 155 2 Randomized controlled trials have reported that biofeedback and electrical stimulation are equally effective. 168,204 Therefore, whether electrical stimulation by itself is helpful remains unclear. A critical barrier in our understanding of the treatments for fecal incontinence has been a lack of comparative effectiveness trials that involve 2 or more therapies. Consequently, it is not known which treatment is most effective for which type of patient and who is likely to benefit the most. Surgery should be considered for selected patients who have failed conservative measures or biofeedback therapy. 205 The choice of surgical procedure must be tailored to the need of the individual patient and can be described under 4 broad clinical categories. 1. Simple structural defects of the anal sphincters. 2. Weak but intact anal sphincters. 3. Complex disruption of the anal sphincter complex, and 4. Extrasphincteric abnormalities. Table 18.4 summarizes success rates for various surgical procedures. 206 In most patients, particularly those with obstetric trauma, overlapping sphincter repair is often sufficient. The torn ends of the sphincter muscle are plicated together into the puborectalis muscle. Overlapping sphincter repair, as described by Parks and McPartland 207 involves a curved incision anterior to the anal canal with mobilization of the external sphincter, which is divided at the site of the scar. The scar tissue is preserved to anchor the sutures, and overlap repair is carried out using 2 rows of sutures. If an IAS defect is identified, a separate imbrication, overlapping repair, of the IAS may be undertaken. Symptom improvement rates of 70% to 80% have been reported, although one study reported an improvement rate of only about 50%. 207-211 Some patients may experience problems with evacuation after surgery. Long-term outcomes of sphincteroplasty, over 5 to 10 years, have been disappointing, with only 30% of patients showing a good outcome. 212 In patients with incontinence caused by a weak but intact anal sphincter, post-anal repair has been tried. 213 The anorectal angle is made more acute via an intersphincteric approach, thereby improving continence. Long-term success of this approach ranges from 20% to 58%. 214 In patients with severe structural damage of the anal sphincter and significant incontinence, construction of a neosphincter has been attempted using 2 approaches. 1. Use of autologous skeletal muscle, often the gracilis and rarely the gluteus. 132,215 and 2. Use of an artificial bowel sphincter, ABS. 216 The technique of stimulated gracilis muscle transposition, dynamic graciloplasty, has been tested in many centers, but results have been disappointing. 217,218 Implantation of an ABS consists of an inflatable cuffed device filled with fluid from an implanted balloon reservoir, which is controlled by a subcutaneous pump. The cuff is deflated to allow defecation. 219,220 A randomized controlled trial has demonstrated that an ABS is better than conservative treatment in improving continence. 221 Long-term outcome studies with median follow-up periods of approximately 7 years, however, have documented success rates of less than 50%, explantation rates as high as 49%, and infection rates of up to 33%. 156,222 Evacuation problems occur in 50% of patients. Rectal augmentation is a novel approach to correcting physiologic abnormalities in a subgroup of patients with intractable fecal incontinence secondary to reservoir or rectal sensorimotor dysfunction. 223 No controlled studies have compared surgical management with pharmacologic or biofeedback therapy, and no controlled studies of the different surgical approaches have been published. Because the outcome of most procedures ranges from significant improvement initially to a less satisfactory result in the long term, no single procedure is universally accepted. In the future, a better understanding of the underlying pathophysiology and development of safer and better techniques, followed by prospective controlled trials, may allow selection of younger patients with well-defined sphincter defects for appropriate surgery. Other procedures. Radiofrequency energy can be delivered deep to the mucosa of the anal canal via multiple needle electrodes with use of a specially designed probe. Seca System Rayfield Technology, Houston, Texas, inserted into the anal canal of patients with fecal incontinence. 224 The proposed mechanism of action is heat-induced tissue contraction and remodeling of the anal canal and distal rectum. In one study, symptomatic improvement was sustained at 2 and 5 years after treatment. 225 A multi-center trial has confirmed the improvements in continence and QOL, at least in the short term, 6 months. Complications include ulceration of the mucosa and delayed bleeding. 226 Interestingly, no changes were seen in the results of anorectal manometry (PNTML) measurement or anal endosonography. A 6-month European controlled study showed that radiofrequency was better than sham treatment, but the clinical impact was negligible and QOL was unchanged. 227 Results of a randomized controlled trial of this method completed in the USA are pending. The Malone, or antegrade continent, enema procedure. 228 consists of fashioning a cecostomy button or appendicostomy. 229 To allow periodic antegrade washout of the colon. This approach may be suitable for children and patients with neurologic disorders. 229-231 Colostomy. If none of the aforementioned techniques is suitable or all have failed, a colostomy remains a safe, although aesthetically less preferable, option for many patients. 132-232-234 It is particularly suitable for patients with spinal cord injury, immobilized patients, and those with severe skin problems or other complications. A colostomy should not be regarded as a failure of medical or surgical treatment. 206 For many patients with fecal incontinence, restoration of a normal QOL and amelioration of symptoms can be rewarding. Use of a laparoscopic assisted approach, a trifine colostomy, may help to fashion a stoma with minimal morbidity for the patient. 235 In one study, the total direct costs were estimated to be $31,733 for a dynamic graciloplasty, $71,576 for a colostomy including stoma care, and $12,180 for conventional treatment of fecal incontinence. 236 Sacral nerve stimulation (SNS) has emerged as a useful treatment option in selected patients, although how SNS improves fecal incontinence remains unclear. 237 The benefit may relate to direct peripheral effects on colorectal sensory or motor function or to central effects at the level of the spinal cord or brain. 238 Earlier studies were performed in patients with a morphologically intact anal sphincter, but subsequent reports have described the treatment in patients with EAS defects. 239 IAS defects. 240 Cauda equina syndrome. 241 and spinal injuries. 242 The SNS technique consists of 2 phases. The first is a temporary trial phase of 2 weeks during which electrodes are implanted in the second or third sacral nerve roots and the nerves are stimulated with a neurostimulator device. If the patient reports satisfactory improvement of symptoms, a permanent neurostimulator device is placed in the second phase, Fig 18.10. Initial reports of SNS have described marked improvements in clinical symptoms and Fig 18.10 plain abdominal film showing a nerve stimulator device, RLQ, along with electrodes, radiopaque, permanently implanted into the sacral nerves. This patient presented with fecal incontinence and underwent a colonic transit study that revealed significant retention of radiopaque markers, which were located mostly in the distal colon, suggesting anorectal outlet dysfunction. QOL and marginal effects on physiologic parameters. 211,243 Results of multi-center studies of SNS have reported marked and sustained improvement in fecal incontinence and QOL. 244-246 A randomized controlled trial found SNS to be superior to supportive therapy, pelvic floor exercises, bulking agents, and dietary manipulation. 247 But long-term outcomes are not yet available. A morphologically intact anal sphincter may not be a prerequisite for success with SNS, and patients with EAS defects of less than 33% can be treated effectively with this method. 239 A systematic review of the published outcomes of trials of SNS revealed that 40% to 75% of patients achieve complete continence, and 75% to 100% experience improvement, with a low, 10%, frequency of adverse events. 237 Percutaneous tibial nerve stimulation. Percutaneous tibial nerve stimulation, PTNS, uses a 34-gauge needle to stimulate the posterior tibial nerve, and through this the L4-S3 nerve roots, to improve fecal incontinence. 248 In a large multi-center randomized controlled trial of 227 patients, there was no difference in efficacy, greater than or equal to 50% reduction in Phi, between the PTNS and sham groups, 38% versus 31%, suggesting a lack of benefit in all comers with fecal incontinence. 248 Another approach for PTNS is to use cutaneous pads, but data are limited. Novel therapies. Several new innovative approaches are being explored to remedy fecal incontinence. A new home biofeedback system that combines mechanical resistance training of the anal sphincter with a self-titrating inflation balloon and gradual escalation of the electrical stimulation of anal sphincter with a voice-guided program has been tested in a randomized controlled trial. 249,250 Home biofeedback appeared to be as effective as office biofeedback, with a clinical response rate of 65% in the home group compared with 60% in the office group in a 6-week randomized controlled trial. 249. 250 Another approach has been to augment the anal sphincter by encircling it with magnetic leads. An uncontrolled prospective study of 35 patients reported 5-year follow-up data in 23 patients, 65%, with a therapeutic success in 63% at 1 year, 66% at 3 years, and 53% at 5 years. Adverse events included 7 device explantations, defecatory dysfunction, 20%, pain, 14%, and infection, 11%. 251 Another novel approach has been to use adult stem cells, especially myoblasts, obtained from muscle biopsies that have the potential for repairing and regenerating damaged anal sphincter tissue. 252 In a randomized controlled trial, intrasphincteric injections of autologous myoblasts or placebo showed similar degrees of improvement in Cleveland Clinic incontinence score at 6 months, primary outcome measure, but at 12 months improvement continued in the myoblast group whereas the placebo group reverted to baseline. Subsequently, the placebo group received open-labeled myoblasts and showed 60% improvement in fecal incontinence symptoms. 253 However, another study that used stem cells derived from adipose tissue showed no improvement in fecal incontinence. 254 A pilot randomized controlled trial evaluated the efficacy and safety of translumbosacral neuromodulation therapy, TNT, using repetitive magnetic stimulation of the lumbar and sacral nerves. 32 Magnetic stimulation at a frequency of 1 Hz showed significant superiority in improving fecal incontinence, with an 88% response rate when compared with the 5 Hz group, 25% response rate, and 15 Hz group, 42% response rate. Such non-invasive neuromodulatory therapies may prove beneficial in the future. In summary, conservative therapies and biofeedback are the first-line treatments. 255 If unsuccessful, sphincter bulking with dextranomer followed by SNS may be considered. PTNS is not recommended, but sphincteroplasty should be considered in postoperative incontinence. An evidence-based summary of current therapies for fecal incontinence is shown in Table 18.5. Table 18.5 Treatment options for fecal incontinence * Treatment quality of evidence medications Diphenoxylate and atropine Fair loperamide Fair amitriptyline Poor cholestyramine Poor biofeedback Good anal plug devices Poor surgery Sacral nerve stimulation Good sphincter bulking Good artificial bowel sphincter Fair dynamic graciloplasty Fair sphincteroplasty Fair colostomy Poor radiofrequency therapy, SECA procedure, Poor novel treatments Autologous myoblast / stem cell therapy. Fair electrical/mechanical resistance training Fair translumbosacral neuromodulation therapy Fair * evidence-based summary Specific subgroups of patients with spinal cord injury. Patients with a spinal cord injury demonstrate delayed colonic motility or anorectal dysfunction that may manifest as incontinence, seepage, difficulty with defecation, or rectal hyposensitivity. 256 Anal sphincter pressures and rectal compliance are low in these patients, but the correlation between manometric findings and bowel dysfunction is poor. Studies of translumbar and transsacral MEPS have shown profound neuromuscular dysfunction affecting the entire spinoanal and spinorectal pathways. 35 Patients with a spinal cord injury may have fecal incontinence due to a supraspinal lesion or lesion of the cauda equina. 100,101 In the former group, the sacral neuronal reflex arc is intact, and the cough reflex is preserved. Therefore, reflex defecation is possible through digital stimulation or with suppositories. In patients with a low spinal cord or cauda equina lesion, digital stimulation may not be effective because the defecation reflex is often impaired. In these cases, management consists of antidiarrheal agents to prevent continuous soiling with stool, followed by periodic administration of enemas or use of laxatives or lavage solutions at convenient intervals. 2 A cecostomy procedure may also be appropriate. 257 In some patients, colostomy may be the best option. 232 Patients with fecal seepage. Because patients with fecal seepage show dyssynergic defecation with impaired rectal sensation, neuromuscular conditioning with biofeedback techniques to improve dyssynergia can be useful. See Chapter 19. 258 Therapy that consists of sensory conditioning and rectoanal coordination of the pelvic floor muscles to evacuate stools more completely has been shown to substantially reduce the number of fecal seepage events and improve bowel function and anorectal function by objective measures. 74 Older persons' fecal incontinence is a common problem in older adults and may be a marker of declining health and increased mortality in patients in nursing homes. 76 In one study, fecal incontinence developed in 20% of nursing home residents during a 10-month period after admission, and long-lasting incontinence was associated with reduced survival. 138 In one report, immobility, dementia, and the use of restraints that precluded a patient from reaching the toilet in time were the most important risk factors for development of fecal incontinence. 17 Usual mechanisms of incontinence include impaired anorectal sensation, weak anal sphincter, and weak pelvic floor muscles. Decreased mobility and lowered sensory perception are also common causes of incontinence. 259 Many of these patients have fecal impaction and overflow. 73,260 Fecal impaction, a leading cause of fecal incontinence in institutionalized older adults, results largely from a person's inability to sense and respond to the presence of stool in the rectum. A retrospective screening of 245 permanently hospitalized geriatric patients 261 revealed that fecal impaction, 55%, and laxatives, 20%, are the most common causes of diarrhea and that immobility and fecal incontinence are strongly associated with fecal impaction and diarrhea. One study showed that impaired anal sphincter function, a risk factor for fecal incontinence, decreased rectal sensation, and dyssynergia are seen in up to 75% of nursing home residents with fecal incontinence. 52,262 Stool softeners, saline laxatives, and stimulant laxatives are frequently administered as prophylactic treatments to prevent constipation and impaction. In a study of institutionalized older patients, use of a single osmotic agent with a rectal stimulant and weekly enemas to achieve complete rectal emptying reduced the frequency of fecal incontinence by 35% and the frequency of soiling by 42%. 263 If fecal impaction is not relieved by laxatives and better toileting, a regimen of manual disimpaction, tap water enemas 2 or 3 times weekly, and rectal suppositories should be considered. 264 In the presence of impaired sphincter function and decreased rectal sensation, however, liquid stools may be counterproductive. Similarly, neuromuscular training to improve dyssynergia in older adults, ritualizing the patient's bowel habits, improving mobility, and cognitive training may be useful. 76 Children incontinence is seen in 1% to 2% of otherwise healthy 7-year-old children. 265 It is due to functional fecal retention, previously described as encapresis, Functional non-retentive fecal incontinence 266 congenital anomalies, developmental disability or mental retardation. In children with functional fecal retention, bowel movements are irregular, often large and bulky, and painful. Consequently, when the child experiences an urge to defecate, he or she assumes an erect posture, holds the legs close together, and forcefully contracts the pelvic and gluteal muscles. Over time, this conscious suppression of defecation leads to excessive rectal accommodation, loss of rectal sensitivity, and loss of the normal urge to defecate. The retained stools become progressively more difficult to evacuate, thereby leading to a vicious cycle. The ultimate result is overflow incontinence, with seepage of mucus or liquid stool around an impacted fecal mass. This aberrant behavior may lead to unconscious contraction of the external sphincter during defecation and cause dyssynergic defecation. 260,267 By contrast, functional non-retentive fecal incontinence represents repeated and inappropriate passage of stool at a place other than the toilet by a child older than 4 years of age with no evidence of fecal retention. According to criteria established by the Rome III Consensus Committee, 266 children with functional non-retentive fecal incontinence often pass stools daily in the toilet, but in addition have almost complete stool evacuations in their underwear more than once a week. They have no palpable abdominal or rectal fecal mass nor evidence of fecal retention on a plain abdominal film, and colonic radiopaque marker studies are normal. 268 The frequency of daytime and nighttime enuresis is higher, 40% to 45%, in children with functional non-retentive fecal incontinence than in those with fecal retention. Children with functional non-retentive fecal incontinence have significantly more behavioral problems and more externalizing or internalizing of psychosocial problems than control subjects. Treatment goals are to remove any fecal impaction, restore normal bowel habits, including passage of soft stools without discomfort, and ensure self-toileting and passage of stools at appropriate places. 268 Disimpaction is best accomplished with oral medication or enemas. High doses of polyethylene glycol 3350, 1 to 1.5 g/kg/day for 3 days, have been shown to be effective. 269 Once disimpaction has been achieved, the treatment should focus on preventing a recurrence through dietary interventions, behavioral modification, and laxatives. Treatment of functional non-retentive fecal incontinence is based on education, a non-accusatory approach, regular toilet use with rewards, and referral to a psychologist. Successful resolution of symptoms may require prolonged treatment and follow-up. 270,271 Resolving parental conflicts and psychosocial stressors and alleviating the fear of painful bowel movements may be critical to a successful outcome. 258,272 The most common congenital anomalies are neural tube defects, e.g., meningomyelocele, spina bifida, and anal atresia, imperforate anus. See Chapter 98. Children with a neural defect or malformation may benefit from behavioral therapy, including a stimulated defecation program, see earlier. 273 Anal atresia is best treated by surgery, but about 20% may have unsatisfactory results. 268 Surprisingly, children with anorectal malformations seem to cope well with their illness. 274 Children with mental retardation or those with a developmental delay may be slow to, or never, achieve full bowel control and require lifelong supportive therapy. Acknowledgement: The author is most grateful for the excellent secretarial assistance of Ms. Helen Smith and Dr. Yun Yan. This work was supported in part by Grant U34, U01 and R21 from the National Institutes of Health. Full references for this chapter can be found on wvexpertconsult.com.